from now. Okay, so welcome everyone. My name is Selena Robinson. I am now running Net Cancer Foundation along with my lovely helpers. Net Cancer Foundation, as I'm sure you all know, was set up by my husband Simon, who sadly passed away at the end of October last year. So he worked very hard on getting you all together and doing this. So this is something that I really want to continue and to do all the things that he wanted to do with it. So thank you very much for coming. I'm really looking forward to this talk, and I will pass you over to Kate to introduce our speaker this month.
Great, thank you very much. Well, it's my pleasure to introduce you Leandro Castellano, who originally trained over in Italy before moving over to Imperial College, where he was for 12 years and was appointed as a team leader and division of surgery, or at even the Division of Surgery and Cancer. And since then, he's now become a reader at the University of Sussex in RNA biology. So he is going to talk to us today about the work that they've been doing looking at non-coding RNAs and looking at both pathways involved in cancer growth and also, more importantly for this talk, how they can be used as biomarkers in neuroendocrine tumours. So please.
Thank you so much, Kate, for the nice introduction from this invitation. I'll try to share the screen. Can you see the screen? Yeah. Okay, can you hear me well as well? Yeah, great. Okay, yeah, as Kate mentioned, today I'm going to talk a little bit about some work that we have done in collaboration with the Professor Freeling. She's the clinician, I'm the scientist, basically. And what we focus in the lab is this small molecule that now we know about that now about 20 years, that are called macroRNAs. And apparently they are really, really useful, can be really useful as biomarkers. So we try to understand whether we can use a macroRNA as a biomarker for small bowel neuroendocrine tumors, and also we evaluated the importance in metastasis as well. Okay, so you probably know a lot about this, but just like to give you a little bit of summary of small bowel neuroendocrine tumors. Spinetta are the most common neuroendocrine neoplasm of the gastroenteropancreatic system, and they arise from these serotonin secreting enterochromaffin cells that are in the GI tract. The incidence is steadily increasing, probably due mostly to awareness of better imaging. Most of these tumors are low-grade lesions, but up to 90% have unfortunately lymph node metastases. And in 45–70%, there are also metastases present at diagnosis in the liver. And unfortunately, these characteristics contribute to a low 5-year survival that is about 60% from diagnosis of liver metastasis, compared to 80% in those with local regional disease. Okay, just to give you a definition of biomarkers, is not always that obvious, I think. So in general, biomarkers can be defined as a biological molecule that can be found in blood, but also in other fluids and also in the tissue, in the cancer as well. And they just can reveal if there is a sign of normal or abnormal process or a condition of the disease. But the biomarker are molecules that can also be used to understand how well the body responds to treatment or disease conditions. Okay, so the biomarker can be obtained using standard or liquid biopsies. So in a standard biopsies, you probably know the tumor is removed and is stained with the particular molecules that are the biomarkers, and can this specific molecule of the tumor can reveal the diagnosis. So if the cancer is there or not, or how bad it is. But a very interesting concept is represented by the liquid biopsies. And the liquid biopsies are represented by the fluids of the body. So, for example, the blood is one of the most used to, and it is obviously much more handy, right? Because it is not invasive and also can be used in case the tumor has not been localized yet, and simply, and the principle is that by using a particular specific analyte, we can understand, we can diagnose the tumor. So that is, so obtaining very good biomarkers from liquid biopsies, it's a very important process, and this can be any sort of molecules from DNA to RNA that can be isolated from plasma, also from serum or the blood, of the whole blood, can be circulating cfDNA or circulating DNA, also microRNAs, or also cells such as the circulating tumor cells that I'm going to tell you a little bit more later in the talk. Okay, one established marker is the Ki67, but this is performed by immunohistochemistry, meaning that the biomarker is assessed from the standard biopsies from the tumor itself, and is used to understand how bad is the tumor. So it's a prognostic biomarker. It can distinguish low to high G1, G2 carcinoma, and G3 grade tumors. However, there are some problems with that. The accurate grading is actually challenging due to intratumoral heterogeneity, and another important thing is that patients that with G1, G2 tumors, they can still develop distant metastases, so that cannot be really prognosticated by the Ki67. So we need additional tool. So therefore, in the subgroup of low-grade G1, G2 tumors with low Ki67, this is aggressive phenotype, but we cannot establish with the marker. Okay, so how is possible that we can detect these molecules into the fluids, into the blood? It is possible because the neuroendocrine tumors arises from cells that act as chemosensors and mechanosensors of stressors. And the important point is that secrete a lot of signals in the local microenvironment and in the circulation as well. So because this signal is specific to these cells, obviously if we increase more than the normal, then it can signal that there are more cells. So there is a tumor going on. So this is the principle. So the NET can secrete a wide range of amine and polypeptide hormones into the systemic circulation, and this has been detected, and some work has been done. And the classical example of circulating biomarkers for gastroenteropancreatic neuroendocrine tumors are chromogranin A. This is bolded because is actually one of the most used in the clinic at the moment. But also other biomarkers such as neuron-specific enolase, pancreatic polypeptides, and hormones that elicit clinical syndromes such as serotonin, insulin, glucagon, and gastrin. So the chromogranin is usually detected in the serum. And these are glycoprotein contained in secretory vesicles. so is a diagnostic biomarker, so it is able to detect whether one person has a tumor or not. The overall sensitivity is 73%, specificity is 95% for neuroendocrine tumor in general. But there are a couple of problems with that. One is that the neuroendocrine tumor is very heterogeneous, and there are several types, and for some types, chromogranin works better than others. So in the end, the accuracy goes actually from 45% to 95% in total. Also, some of the neuroendocrine tumors are not secretories, they are called non-functional, so they do not secrete much of the chromogranin A in the blood. And another important factor is if you include a certain category of patients, such as inflammatory bowel disease, renal failure, atrophic gastritis, or patients that are treated with proton pump inhibitors, a kind of drug, then it really gives a lot of false positives. So for this reason, it's starting to be less and less used into the clinic. So we need something more accurate. Where CGA is the most used biomarker in follow-up of NET, and also it's still used because correlated with the number of liver metastases and tumor burden as well. So is a prognostic biomarker as well. Okay, we need new molecular biomarkers because we want to stratify better SBNet into tumors, different tumor phenotypes. We want to predict how the disease progress, and we want to monitor treatment response and inform treatment options, discover novel therapeutic targets as well, and improve patient survival and quality of life at the end of the day. Okay, so this is a general overview of the biomarkers from Gastroenteropancreatic neuroendocrine tumors. So this can be divided in monoanalytic biomarker, including the chromogranin A, but also other specific factors that are released by these cells, such as amines and other proteins as well. And now the new development is the use of multi-analytic biomarkers that are, for example, the circulating tumor cells. So it's not just measuring a single molecule, but measuring a combination of different molecules. And circulating tumor cells are the ones that are released, that then they go into metastasis, and they are different one of the other, so they can be classified as multi-analytic biomarkers. But also we can measure mRNAs that are released from the tumors into the blood, and this is the NET test, but also macroRNAs, and we're trying to do something about that to be able to use macroRNAs as a test as well. So these are the multi-analytic, so the new generation biomarkers. Okay, in general, so the chromogranin obviously is the most used. So there are extensive studies that support the validity of this biomarker, but there are some problems with that, as I was mentioned before, such as false positive results in case of other conditions. Pancreastatins seems to be better in certain point of view, is a derivative of chromogranin A, because it seems to that is not affected by other false positive rates as chromogranin A, but there are limited studies about this. And there is another molecule that is part of the family of chromogranin A, that is chromogranin B, still limited studies. And then other monolithic biomarkers. But the new idea is multi-analytic biomarkers are much more effective and accurate, such as the NET test, for example. It is an algorithm that incorporates multiple mRNA transcripts in it, of the circulating tumor cells, but the circulating tumor cells, they could be prognostic, but the very limited studies are available, and so it is unsure whether they can be used, and the cost is really high. And finally, microRNAs that we are trying to study further, and unfortunately not many studies are available now. We have done a little bit that I'm going to talk to you about later. Okay, so circulating tumor cells are basically the cells that are released from the tumor when the tumor undergo to metastasis. So what's happening is that cells detach from the tumor start to invade the circulation, and then it start to colonize distant tissues, usually lymph nodes and the livers in case of neuroendocrine tumors. So in principle, these cells are in the circulation. So that means that if you can detect these cells, it could provide an indication that the disease is metastatic. So that is basically all the think about. And the idea is that more cells you can detect, more bad, worse is the tumor. However, the few studies that have been done so far does not provide this correlation between the tumor, how bad is the tumor, and because only about 40% of the tumor in this tumor the circulating tumor cell can be detected in the study that has been done so far. So you can understand that the other percentage of metastatic tumors cannot be diagnosed or prognosticated with the circulating tumor cells. So we still need to do a lot of work into this process. Okay, another very, very promising liquid biopsies approach is the NET test. The NET test, so it starts from blood, and the RNA is isolated from blood. There are these messenger RNAs that can be isolated, and the RNase is converted into DNA, like with an enzymatic process. And by quantitative PCR, 51 marker genes can be measured. And by measuring these genes, two mathematical processes are applied. One is the diagnostic analysis that provide the tumor scores that just say whether the person is normal or has tumor, so it's the diagnostic test, or a second analysis that is called omic index that provide information about the progressive disease, and this is all these measures provide what is called a NET score that also indicate how bad is the tumor, if it's low risk, intermediate, or high risk tumor. And all this process need 8 hours to be completed. So the NET test is valid for many approach. It provides 95% accuracies in case of diagnosis for NET disease, and also evaluate the effectiveness of surgery and whether the disease recur or progress. Also, NET test can be used to monitor the treatment response, where there is stabilization, and also predict whether the therapy, such as peptide receptor radionucleotide therapy, the patients respond or not. So it's a very important biomarker, multi-analytic biomarker. There are some problems with this. For example, it's only performed in Modeling and Wren labs and Yale University. So that means it is not readily available in other centers. And another problem is the cost. The cost is about $1,200 per sample. So we would prefer obviously something that is much cheaper to be widely available for many persons. And also the specificity in patients with oral GI disease or malignancies has not been determined yet. So macroRNAs come forward. So macroRNAs are small RNA, non-coding RNA molecules that are important regulator of cancer-related disease. There is a great interest in macroRNAs as biomarker, as diagnostic and prognostic, and possible therapeutic targets as well in cancer. And at least 60% of coding genes are regulated by macroRNAs in mammals. And macroRNAs are basically important for several cancer processes, such as regulation of cell proliferation, apoptosis, that is when the cells die, or resistance to that, so they are more prominent in regulation of angiogenesis, immune response in cancer, tumor invasion, genome instability, and metabolism of cancer cells. So they are really important for any sort of biological process and any sort of cancer process as well. Okay, just a brief overview, a little bit more scientific, I guess. So macroRNA are transcribed, so means that are produced from the DNA, as happens to the genes. And once these transcripts are produced by an enzyme that's called POL2 or polymerase II, they fold, they form this structure that are recognized by two enzymes, one inside the nucleus of the cells and one inside the cytoplasm. And this double process, nucleolytic process, release a small double-strand RNA molecule that obviously is such small molecule that cannot code for protein, and that stick with the target mRNA. And these are the RNA that code for the protein, but when the macroRNAs guide this protein complex on the mRNA, block the protein translation, so the mRNA does not produce a protein anymore, or at the same time also trigger mRNA decay. So in principle, macroRNAs are downregulate post-transcriptional gene expression. So I mean after the RNA are produced, the production of the product is of this RNA is blocked. And this is important because the macroRNAs repress the expression of genes that induce cancer, or genes that repress cancer, so they can also be oncogenic and tumor suppressor as well. Okay, in terms of good biomarkers, macroRNAs are released in the bloodstream by tumor cells, so they can be found in the blood. The cells undergo the process of death many times, that is called apoptosis or necrosis. And the process of death release any sort of nucleic acids, such as macroRNAs, DNA, and mRNA. But the good thing about macroRNAs is that they are usually complexed into this protein complex. They are not released from there, so they are really stable. So this is a very important characteristic for the use of macroRNA as biomarkers. And they are also actively secreted by cells. So they're not just released by the cells that die, and they remain in these vesicles that are called exosomes. So they steal the exosome, protect from nucleases, so they're really stable. And you know, this is very handy because maybe blood samples can be conserved and can be used later on to quantify the macroRNA transcript without problems, because they remain stable in there. Okay, there have been a few studies that assessed macroRNA's expression is in small bowel neuroendocrine tumors. only a limited amount of studies. One published by Ribble et al. In 2010 performed a differential expression of 95 macroRNAs by using PCR approaches, but only in 16 samples in total, 8 normal and eight cancer, primary cancer, and 8 metastases as well. And they found a few macroRNAs were upregulated and few macroRNAs downregulated. These MIR133A and MIR145 are red because they are the one that we could also validate in our study. And another study by Lee et al. In 2013 used Affymetric macroRNA arrays in 8 primary samples and 16 metastases, and detected 5 upregulated macroRNAs and again downregulation of MIR133A amongst 4 others. But this study were done in tumor samples, so not in the blood. Okay, we performed actually 2 studies in total. The first study was from tumor samples directly, but our study represents the largest global macroRNA profiling of SBNet using matched primary tumors and metastatic samples to date, a total of 90 samples. The aim was to assess the global macroRNA expression in these 90 samples, but using 2 independent cohorts of primary SBNet, matched lymph nodes, liver metastases, and also normal tissues to compare their expression as well. The idea was to understand whether new biomarkers of tumorigenesis of disease progression can be discovered. The strategy used was assessing the expression of 800 known macroRNAs using a technology that is called encounter macroRNA profiling. It is a solution-based hybridization approach that does not require PCR amplification step, because that is important, because sometimes PCR provides some artifact. But the regulated macroRNAs were validated by Tuckman RT-qPCR. And apart from measuring the macroRNAs, we'd also try to understand how these macroRNAs work in SBNet, and using integrated mRNA profiling approach using public available data sets to understand the interaction, which are the interactions that occur in the tumor during the progression of the cancer. Okay, regarding the methodology, we use formalin embedded tissues, and we performed the experiment in 2 cohorts. The first cohort was composed by 15 primary SBNets and 12 adjacent normal small bowel, matched lymph node metastases and normal lymph nodes as well, and matched liver metastases and normal liver as well. And the second cohort, of the validation cohort, was composed by 13 primary SBNets, adjacent normal small bowel, and lymph node metastases and liver metastases. So we only considered the macroRNAs that were common between the 2 analyses, commonly dysregulated, and then we performed the RT-qPCR validation experiment, and also data mining and gene ontology to understand macroRNA-mRNA interactions, and also in vitro luciferase assay that validate the interaction between the macroRNAs and mRNA target. Okay, these are some of the results. So in the, sorry. Okay, so these 2 are the 2 cohorts that we profiled, and we considered only the common hits, and as you can see, there is a very big overlap between the two studies, so this is very significant. And we found these 38 macroRNAs, and then also we compared these upregulated macroRNAs, whether they were also upregulated in liver metastases and in lymph node metastases as well. We found that 5 macroRNAs were upregulated in the tumor, but also in lymph node metastases versus normal tissues, and 29 macroRNAs were upregulated all over the tumor samples, the metastases, and also the lymph node metastases, the liver metastases as well. And then we found also 17 macroRNAs that were upregulated between in both lymph node metastases and liver metastases. And we selected the 3 most upregulated macroRNAs for further validation. So it's always important to use a second tool for further validation. And as you can see, MIR7, MIR204, and MIR375 were upregulated in the SBNet compared to normal tissues. So the overlap of the downregulated macroRNA SBNet and metastasis versus normal tissue was not as strong as the upregulated one. We found 1 downregulated macroRNA, and this was not overlapping with the lymph node metastasis and normal samples, and we detected also 14 macroRNAs that were downregulated in liver metastasis in comparison to normal liver. Also, there was poor overlap with macroRNAs in lymph node and liver metastasis versus primary SBNet. We found 1 macroRNA was upregulated in both liver metastasis compared with versus tumor samples and lymph node metastasis and liver metastasis, and 1 that was upregulated in lymph node metastasis versus SBNet and liver metastasis versus SBNet. Okay, regarding the macroRNAs that were downregulated during metastatic spread, we found 4 downregulated macroRNAs in the metastasis versus the tumors that were MIR1, MIR133A, that is the macroRNAs that have been discovered by other studies as well, MIR145 and MIR1233, and also 10 macroRNAs that were just like downregulated lymph node metastasis and liver metastasis versus SBNet in the second cohort. And this, one of these is 143-3P, that is one of that has been discovered in other studies as well. This is just to say that our data could be comparable to other studies. Okay, yeah. Okay, so as I was mentioned before, how the macroRNAs work is to interact with the mRNA target and to repress the translation of the protein. And this occurs through base complementarity. They stick on a particular nucleotides that are complementary to the one of the macroRNAs. So this principle can be used to actually detect which are the genes that are regulated by macroRNAs to understand how, for example, MIR1 and MIR143 regulate tumor progression. So which are the mRNA target that they regulate to regulate tumor progression. And what we did here was to select studies that perform mRNA expression profiling in SBNets versus normal tissues or SBNet versus lymph node metastases, and to understand so if you consider that the macroRNAs are downregulated, so you would consider that the target are the ones that are upregulated. The mRNA target are the ones that are upregulated because the macroRNA repress. So what we did was to use this study to understand whether there is this particular region of the macroRNAs that can interact with the mRNA to understand which are the targets that are already upregulated in the tumor. So we use the 3 upregulated macroRNAs that we could validate, and we analyze the downregulated genes, and we try to understand which are if they regulate any significant pathway, and the analysis did not show any functional significance. But when we consider the downregulated macroRNAs, the mRNAs that could be target of these macroRNAs, because they were upregulated in the metastases, and in the tumor, we found important processes such as apoptosis, cell death that are important for cancer. So we went on to understand how these downregulated macroRNA metastases regulate genes, and we detected targets that are important for cancer progression, and 1 macroRNA specific target as well. So this means that downregulation of MIR1 and MIR143 could be key in the development of SBNET metastases to reduce the expression of these genes and to increase cancer cell survival as well. So this is what this study in summary shows. And these are some of the experiments that we did. So these are the interaction that we found in these genes, and these are we tested 2 genes for further validation, FOSB and NUAK2, because are known important oncogene in SBNET, and we use some luciferase assay. Luciferase assay to understand whether these mRNA are regulated by the macroRNA target. So when we repress the macroRNAs in cells, we see, when we upregulate the macroRNA in cells, we see downregulation of this luciferase, so the macroRNA is repressing these genes. And when we repress the macroRNAs, we see that the macroRNAs, the genes goes up. Okay, so in summary, we use 2 cohort of studies that contains primary tumors and normal samples and metastases. And with these 2 studies, we did the profiling in formalin embedded tissues of SBNET, and we identified diagnostic macroRNAs such as MIR7, MIR205, MIR204, and MIR375, and anti-metastatic macroRNAs, the macroRNA 143, and using some of these assays, such as in vitro luciferase, we detected that they can directly interact with FOSB and NUAK2 oncogenes to repress their expression and to induce tumor progression. Okay, so the second study that we did was in liquid biopsies, actually, to develop a SBNET test. And this was the largest global profiling of serum macroRNAs in SBNET patients, and was the first study to evaluate longitudinal serum macroRNA expression changes after surgical resection. And we could do that because macroRNAs are really stable again, and we could use a longitudinal study to understand how these macroRNAs work. Okay, so this is the study outline. Here are some of the characteristics of the patients. We use stage 1 discovery using 11 samples. And stage 2 was a validation studies with 33 samples, and the stage 3 was the longitudinal studies to understand how these macroRNAs changing after tumor resection. Some of the only part of the patients were symptomatic. And we also measured chromogranin A as control in these samples. Okay, this is the study line. So in the stage 1, in the discovery cohort, we use 11 small bowel neuroendocrine tumors and 3 healthy control, and we did a comparison to understand whether we can use this, we can detect macroRNAs that can be used as a diagnostic tool. And so far, macroRNAs have been used a lot for cancer diagnosis. There are many studies in general that have used macroRNAs, but still we have to reach a level where we can say that there is reproducibility between labs, because these studies are not reproducible. So what we have done to increase the reproducibility of the usage of macroRNA as biomarker is to use the best tools available, that is Tachman PCR to detect them, and we use the best normalization tool available. So you need to use something that is stable in order to make a ratio and to understand whether the change in macroRNAs level is not due to a different quantity, for example, the samples or different purification procedure, but is actually due because the macroRNA really change physiologically in the tumor. So what we have done is to use the best of this method, that is a genome-based normalization, using 3 macroRNA combination, and only detect the macroRNAs that are consistently regulated by different method of normalization. And we came up with 4 upregulated macroRNAs that are MIR125B, MIR362, and MIR425, and MIR500 in the serum of the tumors in comparison with healthy control. In the stage 2, we validated these results, just measuring these macroRNAs, and we performed a ROC curve analysis. So we measured the accuracy of this test. And in stage 3, we measured only these macroRNAs with Tachman PCR in the prospective longitudinal assessment. And we wanted to understand whether we can evaluate by a simple blood test whether the disease recurs after surgery. Okay, so the method was to use this Tachman array that is able to simultaneously measure the 376 human macroRNAs. And the method of normalization used was global normalization, and GNORM. GNORM was performed using 6 reference genes or 3 reference genes. And again, we consider only the macroRNAs that could be changed using different normalization methods. So in the validation part of the study, we just measured the macroRNAs using Tachman of the single macroRNAs, and as you can see, we could validate that there is an increase of these macroRNAs in the cancer. And we also performed area under the curve to understand the accuracy of this molecule as biomarker. The accuracy, so area under the curve equal to 1 is a perfect biomarker. It's probably almost impossible. More than 0.9 or 90% is an excellent biomarker, and higher than 0.8 is a good biomarker. So these were good biomarkers in principle. They show an area under the curve that is around 80%. But interestingly, when we combine the measure of the 4 macroRNAs combination, we see a very high area under the curve. So 95% of accuracy. That is, it's really good. So that again says that the multi-analytic approach is much better than the mono-analytic approach. Okay, so another interesting finding was that at least one of these macroRNAs could detect SBNET disease after surgical resection. So as you can see here, we have measuring, this is a longitudinal study, so it's a completely independent study. And we could demonstrate that all the macroRNAs are upregulated in the, after, just before the surgery, comparison to healthy control. So we can validate again that there is upregulation of these macroRNAs in the serum of these samples. But as you can see here, after the upregulation, after 1 week, in patients where the tumor was not present anymore, then the macroRNAs disappear, and it goes up again. It goes up in patients that have residual disease or recurrent disease. And that was true for MIR125B only. And here you can see it better, is much larger. So the stars mean statistical significance is higher in healthy control in the preoperative stage. And this is the day 1 after the operation. But as you can see, after 1 month, if the disease is not detected anymore, there is not the macroRNAs present. But it's present in residual disease and in recurrent disease, both after 1 month, after 12 months. So that means that we can understand, simply measuring the MIR125B, whether the disease is still there after surgery. Okay, in conclusion, novel biomarkers are needed to help clinicians in the management of neuroendocrine tumors. Obviously, liquid biopsies are faster, more economical, and less invasive than tissue biopsies, and have the potential to monitor therapeutic response or to predict recurrences to serial sampling. Circulating tumor cells, circulating RNAs, NET test, or circulating DNA and macroRNAs have emerged as prognostic and predictive novel biomarkers in neuroendocrine tumors. Obviously, larger prospective studies are required to fully understand the role of this biomarker and to incorporate them into routine clinical practice. So with this, I would like to thank people that were involved in both studies, with a special thank you to Prof. Andrea Freeling, Dr. Anna Markseva, Ellen, and Dr. Adam Frampton, that they're the one that performed the most of the experiments. Thank you for your attention, and thank you to all patients for donating blood, urine, and tissue samples for research.
Great, thank you very much. That was a really impressive talk, and some really amazing work that's gone on there. If anyone's got any questions, feel free to either put them in the chat or just to sort of raise your hand or unmute yourself and ask them. I mean, I've got a couple of questions that I'll ask in the first instance. So first of all, I was wondering, do you know sort of the genetic status of the tumours that you used in this? So obviously you're looking at what the microRNAs regulate, but do you know what regulates their expression in the first place?
Yeah, this is a very good question, and we don't actually. And I mean, one of the things that we could do is to change expression of transcription factors or processing factor of macroRNAs that are important for the tumor to evaluate whether they change. But the answer is no, we haven't done this kind of experiment, and that would be really interesting to do.
Yeah, well, I was like, so quite often the microRNAs are embedded within existing genes. So I just wondered if there are any obvious sort of locations within the genome, within genes, that might be altered in expression. So whether it would be, whether you've looked. But I mean, my other question, whilst people are thinking, unless anyone's got anything else, was going to be how you envisage these being used clinically. So do you think the microRNAs would be standalone, or will you think of using them alongside other sort of biomarkers that are already in existence, and how you feel those would come together?
Yeah, I mean, I think so. There are many advantages of the usage of microRNAs in the clinic. Unfortunately, as you could see from the number, these studies, these are really small studies as well. We don't have many patients, so at the moment is really difficult to envision a picture of the situation. I think it would be important to use different biomarkers. And we hope that we could develop a microRNA-based biomarker that is cheaper than other systems, such as measuring many mRNA at the time. But yeah, probably. I mean, it really depends, I think, because further studies are needed, and it probably depends how really the microRNA perform in larger studies, because if they are really stable and better than other biomarkers, as we hope, probably you don't need to use others.
Okay, great. Just looking at the chat, although it seems there aren't any questions, but a lot of people are saying that it was a very good talk.
Oh, thank you.
So yeah, thank you very much. I mean, we've only got about 5 minutes left. So Selena, I don't know if there's anything you wanted to say, especially about the next Netchatter next month before we all disappear.
Thank you, Leandro, that was amazing. Very scientific for my brain, but still really interesting. Your diagrams and that were actually, although obviously very scientific for me, diagrams were amazing, and actually it was quite easy to follow.
Okay, so that's good.
Thank you very much for that. Yeah, next month's Netchatter is Thursday, the 28th of April. We will have, our clocks will have gone forward by then. So it will be GMT +1 for everyone not in the UK. We do have a speaker, which Angaraj has arranged. Oh, he's gone. Have you got the name there, Kate? Because I have got it. Hang on. It is someone in Switzerland.
I can try finding it. I was expecting Angaraj to take this responsibility. Yes, so
was I.
There we go. It's Ilaria Marinoni from Switzerland, who
yes, so she is researching pathology. I haven't got the title of her talk yet, so I'm waiting for that. So that should be interesting as well, something else different. So yeah, but thank you so much everyone for coming. It's amazing. And I'm really pleased that we're carrying on this collaboration with everyone, with patients and doctors and researchers all getting together and hearing the new research that's going on. So really, really interesting. It's just because we don't, as patients and things, and as patient supporters, you just don't get to hear about the research side that's going on. So it's amazing. So thank you. So anyone else would like to say anything?
Yeah, just thank you for the invitation. It was a pleasure to present the data.
Thank you very much for accepting. And thank you, Kate, for inviting.
It's quite all right.
So, well, I hope we see you all next month. Just an early warning, there's no Netchatter in May, as we have our second conference. So that will be very exciting. Lots of lovely speakers we have lined up for you. So we will have our ambassador meeting next week just to go over and finalise all those details. So as soon as we've got that done, then we'll start putting it all out there. So you can save the dates in your diary. It will be a Friday in May. So I can't remember how long it is, 2-3 hours. So it will be very interesting. Last year's one went down a storm. So I'm hoping this year will be even better. So thank you very much, everyone, for coming. And we'll see you all next month. Thank you very much. Thank you. Bye-bye.
Bye, everyone.
Bye.